So next up, we have Kristin. She's a social worker at Memorial Hermann. We've talked a lot about how to save these patients. We want to go a little beyond the heart and talk about the mental health of the cardiogenic shock survivor.
Yeah, so thank you so much. Wow, for starters, I can't even believe that we're all in the same room talking about all of these passionate things, and I'm inspired that you are all able to put your life's work into 10 minutes of talking. So I was up for the challenge, and I'm excited for the discussion. So we'll start with making sure I can use the remote. Okay, so no disclosures, no financial obligations, all the fun nitty-gritty that we have to go over. But objectives, what's medical trauma? You're gonna hear me say the word trauma a lot in this presentation. And that's because mental health equals trauma-informed care. That is pinnacle to the success of our patients, our families, and our own well-being as providers. So this is a study that came out last year in 2023, and I want us to take a note of this for just a second, because a lot of the research when I was doing my own digging about trauma-informed care and a cardiac patient, everything seems to go back to the ICD shocks. That's really where the research is. And it's about the fact that most of the people that have an ICD and the ICD misfires or something happens, they develop post-traumatic stress disorder symptoms as a result of that, and that anticipation of another upcoming shock. But why can't we extend this research past the ICD? Why don't we look at research that involves the LVAD, ECMO, chronic illness, all of those things, these advanced therapies that honestly the community is not really aware of unless you watch Grey's Anatomy, and then it's not exactly accurate either. So let's be honest about that. So before we get started, I want us to take a look at two cases. We have Steve. Steve is a 30-year-old male. He's married. He's got 2 infant children. They're probably twins. You know he's not sleeping. And his wife finds him down, and she does CPR on him. And then he's brought in by live flight to the ICU, and he wakes up totally unaware of how he got there and being told that he needs advanced therapies. By the way, you're in cardiogenic shock. What the heck does that mean? But then you have Judy next door. She's 50, divorced, no children. Family probably doesn't live in the state. But she's had heart failure since she was 25 and was managed outpatient pretty well, except she kind of felt a little off, and whenever she brought it up, they said, manage your sodium, manage your diet, manage your lifestyle, and you'll be okay. Now she finds herself as a direct admit from the ER to the ICU for cardiogenic shock or advanced heart failure, and it's because she was non-compliant. So can you imagine being told that after 25 years of thinking you were doing everything correctly? The catch is, it's not up to us to decide, and that's the important thing to remember here. Trauma is anything that our brain perceives as too fast, too much, too soon. It's something that happens to us that we, in whatever place we are in life, do not have the ability to explain, understand, but also in the absence of what is called an empathetic witness. So essentially, you're alone, and you're scared. That's ultimately the formula for trauma. So it's internal, not external. Because I was asked recently, well, how do you know which one is traumatized and which one's not? And I said, it's not up to me to decide. But what my job is to make sure I show up for them. That is what we can all do collectively. And you don't have to have a master's degree in it. You don't even have to have a bachelor's degree in it. You can show up for anybody in the pit that they are, and that is being an empathetic witness. And that's really what trauma-informed care is. It's making sure that you have a safe space. It's ensuring safety. It's ensuring compassion. It's making sure that you collaborate, because ultimately what we're working with here is a loss of control. We have patients who have no control over their environment. There's overstimulation of lights, sounds, strangers coming in your room 24/7. You're told when to eat, when to use the bathroom, and how. And so when you think about what that means for a sense of safety and compassion, that's absolutely something that we can provide our patients. So how do you think your practice would change if instead of showing up into a patient's room and going to yourself, hopefully not to the patient, what is wrong with them? Why are they acting this way? Oh my gosh, I just don't understand. If they could only act their age, how would it change your approach if you switched that to, gosh, what happened to them? What happened to them to make them get to a place where they need to do this in order to feel safe? That's really the shift that we can do here as we continue to work with these cardiogenic shock patients and just heart failure patients in general. So how does this apply to our patient population? If we just look at all the different things that we have these patients going through, to us, it's our regular 9 to 5, right? Or our 7 to 7 if you are in the nursing profession, right? But think about the adjustment to lifestyle. You're told, oh, by the way, the entire life that you have led, Judy, for the last 25 years isn't right. You're going to change. And you got to change now. And we need you to be okay with that. Oh, by the way, Steve, I know that you have 2 twins at home, but now you have to learn how to do a driveline dressing change. And you need to be okay with that. It's an onslaught of information that impacts your sense of safety moving forward as well. But this is what I really want to spend most of my time with. So this is called the window of tolerance. And I know I have no time, but I'm going to be greedy. Who here has heard of the window of tolerance? Ooh, I love that. There's very few people. That means I'm in my crowd. So the window of tolerance was developed by Dr. Dan Siegel. And this has really been adopted as a pinnacle of psychoeducation for trauma-informed care. One of the first things I do with my patients or my clients is I talk to them about what the window of tolerance is. So we're going to do that right now. What that is each of us in this room, if you were born with a nervous system, you have a window of tolerance. And what that is a tiny little spot where you stay regulated. I know I'm in my body. I know I can take in information. I hear what you're saying, and I'm perceiving it and being receptive to it. But what happens when I get out of my window of tolerance? Well, sometimes we can have stressors and we stay within that window. Like somebody cut me off on I-10, and I don't know if anyone drives in Houston, but that's pretty regular. And so I didn't necessarily go out of my window of tolerance, right? But when I found out that my daughter was bit at school by a school bully, I definitely went out of my window of tolerance. So it's up to us what our stressors are that get us out of that window. But what happens when you have a patient who you start to see, okay, you're escalating. You're not hearing what I'm saying. How do you approach that? And in the profession that I'm in, being in social work, 9 times out of 10, and I think you all can agree with me, that you call social work when they're at the peak of the mountain, or you call psych. Right? But what could we do if we were just a little more conscientious of this window and what it might take gently to ease them back into that window of tolerance so they're more receptive? But I also want to point out the bottom, because this is always the one that nobody really pays attention to, and that's because it's hypoarousal. What that means is that's more the fawn response or the freeze response. It's, yes, ma'am, yes, ma'am, yes, ma'am, I hear you. And you probably leave that room going, dang, I'm a good educator. And they see you leave the room and they go, I have no idea what the hell she just said. And so then there's a breakdown right there too. It's because they're telling you what they think you need to hear in order to stay safe. So that's why it's important just to know that this exists. But then there's also a secondary part of this, and that's the caregivers. Think about secondary stress as well. Because we talk to the patient, how are you? I see you're scared. I see you're worried. I'd be afraid too. Do we take just a half a second more to say to the caregivers, I'd be afraid if I saw my loved one in this boat too? Because secondary stress is just as real. Our nervous systems have no idea if they observe trauma or the received trauma. It is going to be perceived the same way, as a threat and a lack of safety. So it's very important to see the caregiver in this as well. And that means you too. We often forget that as treatment providers, as ancillary team, as nurses in the trenches with these patients, we are their caregivers too. And there's often times when we have a patient that we wish we could save, and then we can't. And so how do you take care of yourself? So let's revisit Steve and Judy. Obviously, I don't have time, but amongst yourselves, hopefully during coffee, I would love for you to discuss. Has your perspective changed? Do you think Steve and Judy either or need a trauma-informed care approach, or both? And I hope that this has changed your perspective even a little bit. So the key takeaways here are, it's very easy for us to get caught up in, I don't know what to say. I am so afraid that I am going to say the wrong thing. I think it's best if I don't even go in the room. When really what our patients need is us showing up. We're all humans, we're all flawed, and we're all here just trying to dig out of this pit together. And so just showing up and validating that your experience is real. I may not agree with it, I may not like it, I may not be on board with your decisions, but it is real for you, and I'm sorry. Naming it. Research has shown that if you name the emotion, it dials down the parts of your brain that activates those big emotions and actually helps you to re-engage with the parts of your brain that involve executive functioning, logic, and reasoning. And that's what you need in order to problem solve. So say, I see you're angry. Wow, you look scared. I'd be scared too. And just naming it, because that in itself is bravery. But then also, there's no way that we can all provide trauma-informed care, an empathetic witness, a support system, sense of safety, all for each patient individually. So utilizing your interdisciplinary team before we get to the peak of the mountain, pretty please, and all working together to make sure that we collaborate. That's honestly one of the reasons why the data proves time and time again that support groups are vital. It's because the people who have been through it sit in the same group and they can empathize with that person's experience from a real life experience as well. But then this is what we have control over. We do not have control over where on that window of tolerance our patients are when we walk in that room. We have no control over what got them there. We have no control over what their childhood experiences were that shortened their window of tolerance. What we do have control over is our own window of tolerance. So do you think that if you, being a human being with a nervous system, go into a patient's room, also a human being with a nervous system, and you're dysregulated, how do you think that impacts the patient? So taking a moment to regain control over your own sense of safety, your own body, and learning to read your body is the first step to regaining control and establishing your own sense of safety so that you can co-regulate with the patient. So at the end of the day, and I got greedy, I went over time, but I talked as fast as I could. We can't fix what we can't fix. We can't control what we can't control, but we can show up. Trauma is personal, and it does not disappear if it is not validated. If anything, when it is ignored or gaslighted, shouldn't you be grateful we saved your life? Then that is when it builds and builds and builds because there's nowhere for it to come out. And so thank you so much for allowing me the opportunity to rapid fire 10 minutes of everything that I'm so passionate about, but I'm really excited for the discussion. Thank you.
Thank you so much, Kristin, for that wonderful, excellent talk. I think I've found my own window of tolerance now. And I think it's going to be a great segue into the next topic as well. Were there any questions? I think there's one right there. Yeah.
Hi, my name is Amika. I'm a physician assistant at Nova Fairfax Medical Center in Virginia. At our institution, we're currently working on developing a cardiogenic shock survivor clinic. Particularly to not only care for these patients' cardiac issues, but a lot of the trauma that they incur during their hospitalization. And so my question for you is, after that first initial insult of you being told I'm super sick, you make it out of the hospital, thankfully, how do you, in an outpatient setting, continue to acknowledge that trauma that the patient's gone through and some of the best practices to make sure they're being referred to the appropriate multidisciplinary team members?
Oh, that's a great question. So really in the clinic setting, the first thing that I do is I just show up. Again, that's really what it's about. And so it's consistency. And so if you're the provider that is showing up for them in the hospital, then I would make it a priority to be the same provider that shows up to them at least the first clinic appointment, because the familiar face is going to anchor. It's going to provide that consistency, right? That's one of the reasons why that's so important. But then just letting them tell their story, that's going to be the other piece, because what we need to balance ourselves is to share our story. So I would ask a very open-ended question of, how you doing? How are you feeling? and not in a medical sense. But hey, you made it out. That's awesome. Is it what you expected? Because we can go in with assumptions, and that's the thing we want to avoid. Listen, I'm not in this line of work because assumptions didn't get me anywhere in this line of work, right? So just go in and go, is this what you expected? And being okay if they say, absolutely not, and this is why. But when you give them that space, the point is to make them or allow them to feel safe enough to share with you, listen, this isn't what I expected, and I can't sleep at night. I honestly don't know if I should have gone this route, and I feel suicidal. And it's taking that shame away from those feelings, because if you come into the clinic setting and you say, hey, how you doing? Aren't you so great you're alive? Aren't you so happy that you're out of the hospital? And you install the emotions you wish that they would have, it removes their ability to freely speak where they're standing. I hope that answers your question.
Yes, it did. Thank you so much.
Good.
Excellent. Well, thank you for a fantastic
Thank
talk and
you.
discussion.